My name is Mallory. I'm presenting today on measuring and experiencing skin picking stigma. I think a lot of people have talked about this today, but I would imagine that everyone in this room has experienced stigma in one way or another. You've probably felt the shame that comes with it. Maybe you felt silenced by it. But if I asked, how would you define it? How would you want a scientist to measure stigma? So I became interested in studying stigma and skin picking about halfway through graduate school. I'm currently studying for my Master of Social Work at the University of Pennsylvania in Philadelphia. But I would like to say that I've been specializing in skin picking since early adolescence. I'd always had busy hands as a kid, but middle school is really when I remember the urge to lean into the mirror increasing. I was diagnosed with excoriation disorder in 2018 after years of suffering, really confused and ashamed about how I could be a straight-A student in school and a competitive cross-country runner, but not be able to break a habit as simple as picking at my skin. My family worried that I was engaged in self-harm. My primary care physician wrote me a dermatology referral for acne, where I then encountered lots of doctors saying to just stop picking and maybe wear some more makeup. Yeah. I only sought treatment from a therapist when I graduated high school, and I could no longer do my favorite basic activities like reading a book without feeling the urge to pick at my skin. My story is really similar to a lot of people with excoriation. This data is drawn from the Skin Picking Impact Project, and as you can see on the right, a significant portion of those seeking treatment report that their healthcare provider, whether a doctor or a therapist, has relatively little knowledge about their condition. In fact, you can see on the bottom left that people even experience significant variation in their diagnosis. Even today, our field can't really seem to decide on one name for our condition. I know someone mentioned earlier, but you will hear me switch between excoriation, skin picking disorder, and you might also see dermatillomania in the literature. It's perhaps unsurprising, given these inconsistencies, that people then reported very little change in their picking behaviors, even after seeking treatment. More recent work by a team at UC San Francisco suggests that people with skin picking continue to approach a wide range of providers, from dermatologists to social workers, in order to access treatment. And there's significant variation in the perceived helpfulness of mental health providers versus physical health providers. I would also like to draw your attention to the reasons why people reported delaying or not seeking treatment, as the vast majority relate to anticipated stigma from healthcare providers. This is really important to highlight because encountering stigma can actually increase negative mental health symptoms. So in a meta-analysis of different stigmatized identities, O'Donnell and Ferran found a correlation between experiencing stigma and then experiencing symptoms of depression. And there is also some evidence that more visible conditions have a stronger stigma-depression link. So anticipating stigma is a barrier to treatment. And something we see is that research suggests less than 20% of people who meet criteria for excoriation disorder have ever sought formal treatment. Like we said earlier, prevalence rates hover around 5% of the general population, so this is pretty significant. And people aren't exactly wrong to have hesitations, right? I think you can see across time and across disciplines, training about BFRBs remains stubbornly and woefully lacking. So the Capel study on the right here is actually a follow-up from Marx's initial study back in 2006. So since that initial study, BFRBs and specifically skin picking have been added to the DSM, but we still see a lack of information for clinicians. However, in this follow-up study, they also found that 80% of those that they surveyed reported a desire for more education about how to serve patients with this condition. So that really gives me hope. But in order to address the gaps in knowledge, we really need to start upstream. My current research focuses on identifying the presence and nature of stigmatizing attitudes among healthcare professional students, because this population is ripe with potential for shaping the future of treatment. I've modeled my study design and instruments off of Dr. Rebecca Pearl's work on stigmatizing attitudes towards people with psoriasis among both medical students and the general public. Her team found that while both groups stereotyped people with psoriasis, medical school students reported on average less stigmatizing attitudes than the general public. However, we know that people with mental illness tend to face more public stigma than those with physical conditions. Excoriation disorder sits comfortably between the visibility of a skin condition, and we also have the concealability of a mental health condition. So as a result, I've chosen to focus on recruiting 3 groups: medical students, dental students, and social work students, in order to develop insight into how physical health practitioners in training may perceive people with excoriation differently to mental health practitioners in training. So, I'm using a quasi-experimental self-report survey hosted on Qualtrics. People answer a series of demographic questions, then they read a short informational passage about skin picking disorder before entering the visual stimuli portion. So people will see a series of 10 images. These are just a few examples. Each image appears on their screen for 5 seconds. All images were taken from DermNet, which is an online free database of skin conditions that's created and maintained by healthcare professionals. And so just wanted to include a few examples here today. And then after viewing these, participants get asked to respond to a number of scales and questions about their perception of the people in the images. And by a few questions, I do mean adapted versions of the following scales. I do believe that measuring something as complex as stigma demands a multifaceted approach, but as one of my med school friends kindly told me, that's kind of a lot of questions for me to answer. So I'll break it down here briefly. Emotional response items, and these were all adapted from Dr. Rebecca Pearl's work, essentially just changing the language from psoriasis to skin picking. So emotional response items ask participants to rate the extent to which they feel pity, compassion, etc. for people in the photos. Desire for social distance scale, one of the oldest used measures for measuring stigma, asks participants to rate their desire to avoid people with excoriation in a variety of social situations, ranging from going on a date to sharing a carpool. The stereotype endorsement scale, people rate how much they associate those in the photos with a certain adjective, such as people with excoriation disorder are insecure or unintelligent. And then lastly, we measure myth endorsement by asking participants to rate how much they agree with a series of statements representing misconceptions, such as people excoriation disorder is caused by poor hygiene or taking drugs. So far I'm in the data collection phase. I have a target sample size of 200, and I'm about a quarter of a way there in a little under 2 weeks, which is very exciting to me because I have no funding for this project, so I'm asking people to do it out of the kindness of their hearts. So here's a little bit of what people are saying so far. I do have a qualitative question at the end asking about general thoughts and feelings after taking the survey. And these responses, I won't read them out, you can do that, but these responses really speak to the underlying motive for my work. After all, why would I want to spend hours collecting and analyzing data about the stigma people might hold towards me and others with my condition? But really, what I'm driven by is a vision for the future that includes psychoeducation tailored to the specific needs of different populations. Identifying the current gaps in knowledge is the first step to more effective and targeted training, and I ultimately believe more empathetic treatment for people with skin picking disorder. Thank you so much for listening. I've got my references, and then you're more than welcome to get in touch. So thank you so much.